Now we're going to kind of meet the winning companies. About 90 seconds each for them to introduce themselves, what problem they're solving, how they're solving it, what are some of their accomplishments to date. I'll try and ask a smart question to follow on.
My name is Jenna Quinn, CEO and co-founder of Perfecting Peds. I've been a pediatric pharmacist for over a decade prior to starting my company, Perfecting Peds. I'm also a mom to 3 little girls that keep me going every day. So the problem that we're trying to solve is that 1 in 3 scripts that are written for a pediatric patient actually contain a medication error. So that's alarming. That's 3 times that of adults. 50 to 75% of prescriptions that are written for children actually are not optimized. Why does this occur? Well, as I see, I have a panel of amazing pediatricians on, but during school, medical school, they usually only do 1 to 2 semesters of pharmacology. And then they're expected when they start practicing as pediatricians to be able to flip from, their core 20 to 30 meds into subspecialist medications. And so once the subspecialist takes over, the pediatrician hands it off. And we're really relying on the retail pharmacies and pharmacists to be that person that owns the entire medication regimen of the children. A lot of people aren't aware that a retail pharmacist, most of them throughout pharmacy school, do not have any exposure to the pediatric population. They have no pediatric pharmacology mandate in pharmacy school. Because of this, the pharmacist also does not have the child's weight. So there's no way for the retail pharmacist to actually validate that the script is appropriate for the patient. Because of this, I formed Perfecting Peds, noticing that in my practice, I was constantly intervening on the child's chronic medications, in addition to my own children, realizing that a lot of scripts need to be optimized. So what I did was, for lack of a better word, put my sales girl hat on and was able to take care of our first 102 kiddos where we piloted, putting this highly specialized pediatric trained pharmacist that did pharmacy school, residency, and Peds pharmacology certification and put them in a longitudinal fashion into the ambulatory care space and the collaborative care team of pediatric patients by way of their caregivers or the patient themselves. What we found was really exciting. It was a 44% reduction of hospital admissions, a average of 13 interventions, and a cost savings of the decrease in total cost of care of $1.1 million in indirect and direct costs for these first children. So what we did, we took that pilot and we pivoted, and now we partner with payers. And really what we focus on is partnering with the caregivers and the patient and following them in both a reactive and proactive fashion using technology for our reactive CMMs. And we're with them till 24 years of age.
Fantastic. Pharmacists have saved my rear end many times on the ward, especially in pediatric hemonc. So thanks for what you're doing. Real quick, short answer, who pays for this? Because it's a big unmet need, but how do you get it paid for into the workflow?
Yeah, so we do contract with facilities and providers, but that's how we started. We've turned our model completely to payers. So healthcare plans actually attribute us patients and we enroll them. And like I said, follow them at least 4 times a year, but upwards to 12 times a year, reacting to new medications, changes in social determinants of health, as well as admission, discharge, and transfers.
As we know, again, I'm training pediatrics and internal medicine, but we've also seen a dearth of solutions in the pediatric space where they don't get adopted or paid for, just like in the challenges across the adult world. What lessons have you learned that are unique to getting solutions out into the kids space, whether it's a pediatrician, physical therapy, and beyond? Any kind of quick lessons or insights?
Similar to what Natalie said, basically for us, it was showing basically our ROI, just as she said, but using pharmacoeconomic analysis, which is something I didn't really know I'd even need and didn't pay much attention to in school, but it's just so important because it's attaching the dollars and senses to what you're doing. Although my ultimate goal as a clinician is optimize the child's quality of life through optimized med management, what speaks to the payers and the health plans and the people who are making the monetary decisions a lot of times is knowing that you're going to drive down the total cost of care or have a decent ROI of over 3 to 1. Another thing that we've been able to do here is I will advocate we're all pediatrics. The caregivers and the patients can be our biggest allies. I've actually gotten care plan contracts because we have caregivers who have gone to the head of the CMOs and people in the health plan saying, you should absolutely cover this service. And then I think third and the last one, because it's a long-term play, is using legislation. So, for example, in the Medicare space, for Medicare Part D, it's a mandate that a pharmacist is assigned to a high-risk geriatric population, whereas in the pediatric space, that's not a mandate. And so how do we follow suits of what has worked in adults and geriatrics to change the legislation so that we can get the payments that we deserve as pediatric professionals?